My name is Victoria Scatia, and the title of this presentation is The Mitigation of Race-Based Antihypertensive Prescribing. Guidelines for the management of hypertension in Black patients is historically divergent when compared with patients who do not self-identify as Black. Black patients are preferentially prescribed thiazide diuretics and calcium channel blockers as initial single-agent therapy in lieu of ACE inhibitors and ARBs. Unfortunately, these practices are in alignment with current clinical guidelines from multiple national organizations, including the American Heart Association. These clinical guidelines are informed by antiquated landmark clinical trials, most notably the ALLHAT and AASK trials, whose validity and results have recently come into question, citing poor study design and implicit assumptions regarding race as biological rather than a social construct, interfering with data analysis and generalizability of the results. In 2022, a former DNP students project found that nearly 50% of providers at a large urban academic medical center consistently considered race when deciding which antihypertensive to prescribe. The purpose of this project is to build upon the results of this 2022 DNP project to develop, implement, and evaluate an educational tool to deliver evidence-based, race-neutral recommendations for antihypertensive prescribing to a cohort of internal medicine residents. Currently, the site's internal medicine residency program does not include didactic sessions devoted to the role of race in medicine nor antihypertensive prescribing. Our education aimed to bolster knowledge and awareness of the antiquated use of race in antihypertensive prescribing and in medicine more broadly. From a methods perspective, our intervention consisted of an adapted curriculum called the Educational Toolkit, which was administered to 102 internal medicine residents PGY 1 through 3. Our results found that half of the residents reported being unaware of race-based considerations within the current AHA and JNC hypertension guidelines, and nearly 70% of the residents were unaware of the ALLHAT or AASK trials. Residents were asked to review clinical vignettes of a Black, Asian, and white patient with hypertension and select an appropriate monotherapy option. When prescribing for a Black male, 63% of responses selected either a calcium channel blocker or a thiazide diuretic. When asked to expand upon their decision, 47% of the responses included explicit mention of the patient's race, making calcium channel blockers or thiazide diuretics a preferred option. On the graph below, pre-test survey findings demonstrated that more than 50% of the residents agreed or were neutral in their belief that race is an important factor in deciding which antihypertensive to prescribe. Following our intervention, more than 88% of the residents either disagreed or strongly disagreed with this sentiment. Moving on to discussion and recommendations, our pre-test surveys re-demonstrated a reliance on race when selecting antihypertensives among our target audience. On post-test surveys, we found that 86% of the residents reported increased comfortability discussing the concept and outcomes of race-based medicine with patients, peers, and precepting attendings. Over 80% of the residents reported an improved understanding of race-based medicine, and ultimately, more than 90% of the residents either strongly agreed or agreed that they plan to eliminate the use of race when prescribing antihypertensives. From a sustainability standpoint, we are currently in the process of integrating our race and medicine curricula into the 2025 internal medicine rotation and hope to expand awareness to other topics, potentially including PFTs and DEXA scans. In conclusion, a large gap exists between research, recommendations, practice, and control of hypertension in the United States, especially for individuals of color. In 2020, the American Heart Association released a statement acknowledging the role of structural racism in cardiovascular disease, but failed to provide updated clinical guidelines supporting their call to action. Please join me in this effort by seeking out opportunities to get involved in local anti-racism committees and initiatives within your own areas of practice. Thank you.